Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Weight Watchers. We would like to remind you that the chat feature is available, so feel free to send in your questions for the panel throughout the discussion. Our speakers would love to hear from you. And with that, I will turn it over to our moderator, Eva Vias.
Welcome, everyone. Thank you for joining us today, and we're so excited to have many of you here as we examine the ROI of GLP-1s. I am Eva Vias, Head of Healthcare Market Access at Weight Watchers, and I will be hosting today's discussion. I'm pleased to have with me today Dr. Amy Meister, our Chief Medical Officer, and the third-party consulting firm, Santa Barbara Actuaries, with Rich Gamrat. And I'll ask Rich and Amy to introduce themselves here in a minute. I'll just share with you our goal today is to examine approaches to weight health and GLP-1 coverage and how to look at this investment, acknowledging that GLP-1s are both costing and saving money. We'd like to share both an offensive and a defensive model as we explore the only third-party validated ROI model for the employer market until now. And that's been developed in partnership with Santa Barbara Actuaries. We'll share both the short-term and long-term effects on an organization's healthcare costs. So without further ado, thank you again, Amy and Rich, for taking the time today and really looking forward to our discussion. Amy, would love to have you kick it off. Would love to have you share your background.
Thank you, Eva, and thanks to everybody joining us today. My name is Dr. Amy Meister. I'm an internal medicine physician by background. However, I've pivoted away from traditional practice over the past 15 years and have been focusing heavily on the employer and payer spaces. I've been closely following the impact of obesity-related chronic conditions on medical and pharmacy trends over the past several years. And all eyes are on the GLP-1 class of medications, not just because they've demonstrated superior clinical efficacy and are well tolerated, but also because of looming supply shortages and their excessive price. We're going to dive into the anatomy of an ROI model of these GLP-1 medications. Employers and payers alike are facing a big challenge and are trying to look for ways to help solve how can they offer this latest and greatest medical therapy for the treatment of obesity in a fiscally sustainable way. Without further ado, I would love to turn things over to Rich, who is with SBA Actuaries, who helped us think through this very critically. Rich?
Good afternoon, and thank you for having me. My name is Rich Gamrat. I'm a managing director and consulting actuary with Santa Barbara Actuaries. I'll call it SBA for short. Our firm specializes in assisting many entities within the healthcare ecosystem evaluate what value, both clinically and financially, can come from altering traditional care pathways. The majority of our clients participate in value-based care. In my prior life, I was the lead actuary for a multi-state MA plan. Throughout that work, I would evaluate many ROIs that were presented to us from the payer or provider side. Now, as a consultant, I frequently develop ROI or value creation estimates on behalf of my clients. We assist a wide variety of clients, including payers, providers, employers, health science companies. Some of the areas where we've modeled value creation in the past include surgical decision support, medical devices, oncology management programs, weight loss, hospital at home, transitional care management, high-touch services that focus on treating members with multiple chronic conditions, and risk accuracy initiatives in the MA space. Recently, I've had the pleasure of supporting and partnering with Weight Watchers to evaluate the ROI from their behavioral change and GLP-1 medication management as it relates to weight loss. And I'm very looking forward to being here today.
Great, Rich. Yeah, go ahead. Love for you to get us started here and help us build some foundational knowledge of what an ROI is and why it matters and how we should be thinking about it.
Yes, thank you, Eva. ROI is going to matter for a lot of reasons, but generally speaking, in most business senses, an ROI is going to be the gold standard for evaluating your return relative to your investment. ROI calculations in general will summarize the financial value created by something. In this case, in our conversation today, it's going to be the positive effects of weight loss on your employer population. There's certain things that are not captured by an ROI. Some of those are going to include the softer benefits like employee satisfaction and retention that are more difficult to monitor on a dollars and cents basis. With all that being said, when you're considering adding a weight loss program, it's really difficult to evaluate the true net cost of a weight health management program without reviewing the ROI. And the reason there is there's a time delay from when you make the initial investment to implement a new program or new medication relative to when the employer will feel those benefits of the reduced weight loss, improved productivity, or reduced absenteeism. As we think about ROIs are complicated, and many ROI calculation or value creation estimates rely heavily on the underlying assumptions. So as we work through this presentation, we're going to talk about being a good consumer of an ROI. So just keep in your mind as we're working through these slides that all ROIs are only as good as the underlying assumptions. Generally speaking, in healthcare, many of the ROI calculations require actuaries. Unlike an ROI calculation in many traditional business sense, where you're considering adding a sales team and you can easily monitor new leads or new sales that happen. When it comes to healthcare ROI calculations, oftentimes we need to evaluate the value of something that did not happen. Because we're evaluating something that did not happen that would have otherwise happened, it can be difficult, and that's where actuaries come into play to apply our statistical methods of forecasting. And last but not least, but an ROI calculation will enable employers to make data-driven decisions. Healthcare interventions are expensive and administratively burdensome, and so reviewing ROI can allow you to focus your efforts where you'll see the greatest return. Thank you, Eva.
Great. If we move to the next slide, we talk a little bit about the formula for weight health and the how an ROI is put together. And then Amy, I'd love for you to share a little bit about some of the clinical context around the ROI as well.
Yeah, so this is the formula that we've used to evaluate ROI in our prior modeling. And generally speaking, there's going to be two components. There's the financial value that's created relative to the incremental expense. And now when you think about ROI, what's really, really important is the time period. The time period matters very much on an ROI calculation. And in general, what we're evaluating is the incremental value created by manipulating a care pathway in the ecosystem. And so to do that, most times we're going to evaluate costs and value under a base case relative to the cost and value under a future state. Once the program has been deployed. Generally speaking, the ROI is only going to focus on quantifiable value levers, and it's going to exclude non-financial value levers, like I said, employee retention. This is something that's really important to consider as we're talking about ROI. Depending on who you're speaking to at your organization, their off-the-shelf definition of ROI may vary. Generally speaking, in the finance space, so if you're talking to an actuary, an accountant, the CFO, the financial definition is going to measure net value created, which means it's value created less expense. In the healthcare space, it's very common for entities to use gross value created. That's one thing that's very important to keep in mind as you're comparing ROIs across different vendors. So what does that really mean? Let's say, and what's really important is if you're reviewing a one-to-one ROI in the healthcare setting, that is going to correspond to a break-even scenario where the value that's created is equivalent to the incremental cost. If you're looking at a one-to-one scenario under the finance definition, you've effectively doubled your money. So keep that in the back of your mind as you're reviewing these ROI definitions.
Thanks, Rich. And from a clinical perspective, what we do know is healthier people consume less healthcare resources. Specifically, healthier people have less unplanned care, like expensive emergency department visits, inpatient stays, and surgical care. The other thing that's important to take into consideration as well is that although the GLP-1s can take up to 5 months to ramp up to their maximum effective dose, many people experience clinically significant weight loss within the first month, and they start feeling better. And although this is more on the VOI side of things, when you have somebody that feels better, often that helps them show up better at work and decrease presenteeism and absenteeism. Lastly, I think it's also important to note that if somebody in their weight journey has a good support network and starts down that journey of losing weight, becoming healthier, and even getting to the state where you're able to start seeing some disease remission, so perhaps not needing as much in terms of blood pressure medication or diabetes medications, we're doing whole person care and focusing on the family unit or who else they live with. Hopefully the next generations to come, this will be an investment of teaching them healthy lifestyles as well. So not just the person that's actually going through the weight journey themselves, but also the downstream impacts on people that live in their same households or dependents that are also on their medical plan.
Rich, can you talk next about kind of whether or not we're really measuring the right things and how people would think about what are the appropriate levers to measure as we think about the ROI model?
Yes, Eva. First off, ROI is complicated and it's difficult to be a good consumer of ROI. It's not infrequent to see multiple entities produce an ROI on a similar topic, but results can differ significantly. So as you're comparing ROIs, there's a number of things that should be considered. And the first is which methodology is right for you. Generally speaking, we end up reviewing two types of methodologies, prospective and retrospective. Each will have its own pros and cons. Generally speaking, prospective assessments can be tailored more closely to represent a potential employer or prospect situation, but they're going to likely depend on assumptions about what will happen in the future. How many members will engage? What is the current distribution of obesity? When you look at retrospective is a rear-looking evaluation of what were the financial and clinical results of a specific deployment on a specific cohort of members. While a retrospective is great, many employers, I think, have a potential to overgeneralize and apply results from one employer to another. And generally speaking, results from one employer to another won't translate at a one-to-one. Secondly, the underlying assumptions. Assumptions are very important. If you've ever read an actuarial document, results will depend on assumptions. It's a standard caveat. In this case, we have to make numerous assumptions, both clinical and financial, to project the value of the ROI. As you're reviewing this, you should ask, are these assumptions reasonable? What is supporting this assumption? Is it prior claims data? Is it an industry study? Is it a peer-reviewed medical journal study? Generally speaking, the sources for specific assumptions matter a lot, and you should be critical of those assumptions. A second question you should ask yourself is, what will happen to my results if these assumptions do not materialize? Generally speaking, we're actuaries and we're good at projecting the future, but we're not fortune tellers. So certain assumptions can and will vary. And you should understand if those assumptions vary, what direction could it cause our results to change? Some really important things as you compare ROIs. I would be very cautious whenever you hear a phrase of up to. Up to generally indicates a selective approach to review a result on a minimal cohort of members where maybe they could see an elevated outcome. Really focus on the big picture, avoid cherry picking, and evaluate all members that could be eligible for that program or intervention. And lastly, start with the end in mind. there are no cure-alls. There's no miraculous free lunches. Generally speaking, an ROI should be reasonable and believable. For most of the ROIs we've either developed or reviewed, generally speaking, an ROI is going to be at 4-to-1 or less. Like I said, there's no free lunches, there's no magic cure-alls. And as an employer, you should ask yourself, would I rather see a very high ROI or one that's more realistic and supported with reasonable and assumptions that will actually materialize? It's very important. As we've reviewed ROIs in this space, we've seen entities focus only on a very, very high BMI starting point because that generates a really, really wonderful soundbite for a sales process. But again, focus on the whole population. There's another way to look at this is not only what should I consider when reviewing an ROI, but as from the employer's perspective, what ROI do you need to see from a program? Some employers will set a minimum threshold for ROI. Generally speaking, when we work with employers, we would suggest that a program such as the Weight Watchers one that generates significant goodwill with the employees does not need to produce an ROI that's as high as a program that doesn't create goodwill, I should say, that's generated on a management function or an administrative task that really produces financial savings. If there's no member goodwill, generally speaking, employers are expecting a higher ROI. And when there is goodwill, generally an employer was very happy with a lower ROI. Amy, would you like to add anything?
Yeah, so overall, when we start thinking about ROI, when I've talked to hundreds of employers, I really was able to kind of separate them into two buckets or two camps. Camp number one would be what we call the defensive camp. And those are employers that currently cover the GLP-1 for the treatment of obesity. And they're trying to build their business case and clinical case to continue to cover the medication. In the second camp, it's really what we call the offensive model. And that's for employers that are looking prospectively in the future, seeing perhaps increasing prevalence of chronic conditions, and really trying to understand how treating obesity now can help decrease future claims and how to justify the costs. So think of those in two very different specific swim lanes in terms of what to cover and what the different driving issues are to help justify the costs.
And these value creation approaches, what we've received feedback, there's through our conversations, employers tend to be at one of two spots. As Amy said, the defensive position. Now remember, all of our ROI modeling is comparing base case to future state. And so for the defensive model, this will apply many times to employers that have already added GLP-1 medications for weight loss. They're seeing uptake in prescription rates and fill rates, but they're also seeing increased costs. And they're interested in adding a behavioral health program management to sit on top and manage those expenses. Generally speaking, adding that behavioral program can allow potential de-escalation and act as a cost control mechanism for employers who are already covering GLP-1s for weight loss. On the other hand, we've spoke with employers that want to add the behavioral program and begin to cover GLP-1 medications. So as you think about what's right for you, you'll need to consider where your employer is on the weight loss spectrum currently, and are you covering GLP-1s or are you not for weight loss?
Now, one other key point I want to throw in on the defensive model, and we talked, and I see some comments and questions coming in about de-escalation or intolerance of medications. And one thing that's really important, first, I've been prescribing GLP-1s for people living with type 2 diabetes for over 15 years. And they're actually pretty well tolerated over a period of time. I think why we're seeing some intolerance perhaps in people living with obesity as opposed to the original use case and indication is one, that many of these individuals don't have other chronic conditions, or they could, or they're not used to chronic medication therapy. And it's a commitment to take a medication. Additionally, they are very effective, and sometimes people are able to meet their goals sooner than what is anticipated. And although there is much debate in the medical community about being able to de-escalate medicines and whether you need a GLP-1 for life or not, we believe that there are what I'll call phenotypes that do very well with de-escalation to either behavioral therapy alone, or perhaps a less expensive medication to the first generation anti-obesity meds, or even some off-label use of medications like metformin. And what I mean by phenotypic expression is somebody that perhaps has a specific, it's the context of obesity or context of care. What drove a weight loss or weight gain issue? So for example, pregnancy, going through a change in job, or perhaps a financial problem like bankruptcy. If there are different things that can influence your access to food, or perhaps activity like going through a car accident and having a pelvic fracture and not being able to exercise for a period of time, all those things would lead to us thinking about somebody having the potential to come off of the GLP-1 medications and be de-escalated to behavioral therapy alone, or to a less expensive medication. And that's a decision that needs to be made between the prescriber and the patient in a shared decision-making model. And a lot of it also comes from most of the patients we treat in obesity care don't really want to be on medicines forever. Nobody likes taking pills or taking injections, and they're looking for solutions to help them overcome the acute issue and get back to a previous state of health.
Thanks, Amy. That was really helpful. I know you mentioned earlier that you have been talking to many employers and payers related to GLP-1 and coverage and other issues. You know, these two situations and scenarios are I think are top of mind and what has come up over and over. There's another scenario, I think, that a question that we're seeing in the market as well, about some organizations deciding or contemplating the idea of stopping coverage. Which of these value creation models might somebody look at as they're contemplating maybe even that type of a scenario?
So if you're thinking about stopping, the model would be the more of the defensive model, because that is when you're already covering the medication. But it's almost a combination of the two, because you want to be really mindful of what happens if you stop the medication in terms of the prevalence of chronic conditions and your total cost of care spend. We're also seeing a significant increase in pharmacy trends related to GLPs, but not just because of obesity. One of the things that's happened in guidelines over the past couple of years is a change in the recommendation. I remember when I first, back at 25 years ago, started treating people living with type 2 diabetes. At the time of diagnosis, the original algorithm included intensive lifestyle therapy for a period of 3 months. And then if they didn't make enough progress, then you started adding a first generation medicine like metformin or a sulfonylurea, which unfortunately, although are very affordable, the sulfonylurea family can cause, they're actually obesitygenic. So then came the next generation of medications to the marketplace, which said, okay, you've done the lifestyle therapy, you've tried a first generation medicine, your diabetes is still not at target, so now you can add the GLP-1. What's changed recently within the past year and a half is that you can start from day one, not just with pharmacotherapy, but you can start with a GLP-1 right out of the gate. So we're seeing a lot of increased utilization of GLP-1 medications for the treatment of type 2 diabetes. And we're going to talk a little bit later on about the importance of thinking about a utilization management program to make sure that people that are using the drugs under the indication of type 2 diabetes truly have type 2 diabetes. And the last thing that I'll say on that topic is that people living with type 2 diabetes actually lose less weight on a GLP-1 than those that don't.
Thanks, Amy. So if we maybe let's dive into the model a little bit and talk about both of the mechanics of the models. And Rich, I see some questions coming in as you cover this on, you know, what's the underlying claims information that might be factored into this, as well as thinking about the time horizon related to employee retention and how long people are with an organization or with a payer, and how that might factor into the model and the output of the model.
Yes, thank you, Amy. So here's a quick summary of what I call the important bullet points for each of our offensive and defensive models. Now, generally speaking, for value creation levers on the defensive side, the big driver there is going to be medication de-escalation, reduced clinical expense, an incremental BMI reduction. And when I say incremental, it's not the full BMI reduction that's attributed to the GLP-1, but there's a small chunk of additional weight loss that happens by stacking the behavioral program on top of that GLP-1. When we look at the offensive model, the big value lever there is going to be the total BMI reduction. So that's all weight loss that happens not only from both the GLP-1, but also the behavioral program. We've also reviewed reduced absenteeism from our research. We've seen that members at a healthy BMI tend to miss fewer days of work compared to members or employees at a higher BMI, as well as short-term disability reduction as well. From an incremental cost, right? The items that we reviewed on the defensive side are basically additional behavioral program costs that are added on top of the existing cost of the GLP-1. Now, when we look at the offensive model, there's a much greater cost hurdle because not only do you have to consider the net drug expense, and the net drug expense is important because you should consider items like co-payments and rebates, which reduce gross drug liability to the net drug liability, but we look at the additional program costs. One key difference between both models is the time horizon. Generally, you can achieve an ROI more quickly with the defensive model. The modeling work we've done so far is at 2 years for the defensive approach. In the offensive approach, all of our work has been 3 or more years. Now, both of these models, we talked about this earlier, there's 2 types of methodologies. There's prospective and there's retrospective. Both of these were constructed using the prospective methodology. And as you're considering both of these, really the item that helps you pick which camp you may or may not be in is, are you currently covering GLP-1s for weight loss? If so, look at the column on the right for the offensive approach. Or, excuse me, if you're currently covering GLP-1s for weight loss, you would most likely be in the defensive camp. If you're adding coverage for GLP-1s, you'd be in the offensive camp. I see a question here. Are you seeing payers and employers lean more towards the defensive approach or the offensive approach? I will say in my conversations I've had, it's mixed, about 50-50. A lot of the earlier adopters of the GLP-1s are very interested in adding additional health management programs to accompany the GLP-1. But Amy, I'd love some feedback on that question from you as well.
Yeah, absolutely. So really important in terms of thinking about the GLP-1 coverage overall. Some of the differences that we're seeing in the 2 models are really looking back across time, making sure that the people that are taking these medications are the right people taking them. Really important to have that utilization management function in there. And also important to think about, if you're covering them for weight loss, is there a duration that you want to cover them? Although from a pure clinical lens, a physician will tell you that it's about the individual presenting in that evidence-based medicine. There's no instant cutoff for which we would say you should only cover the medication for, say, 10 to 12 months. Although we'd love to be able to tell you that's a hard and fast rule, clinically, everybody responds differently. So those are some other things that if you're considering uncovering the medication, to really be mindful, particularly if picking a clinical partner or deciding who's going to be in your network of prescribing and what type of therapies that you want to involve in your obesity care formulary. It's really important to make sure that you always anchor to the good clinical side of evidence, and to make sure that realize that nobody's bodies are identical and they didn't all read the same book. So in terms of duration of therapy, it's going to depend on a clinical response.
Thanks, Amy. Maybe we can dive into some of the points you made earlier, Rich, about the importance of really thinking about the underlying assumptions. And so I know you you have some thoughts around the underlying database that you utilized in terms of the level of high claimants that might be involved, but also some of the population distribution assumptions that we've modeled as well. So if you could dive into some of these categories and give some examples of how individuals might be thinking about the assumptions.
Yes, thank you, Eva. So from a database perspective, we use the market scan database to evaluate the potential claim reduction as members transition from one obesity to a lower obesity state. We deployed a matching process to identify that BMI is reduced. But we've also evaluated a number of very important assumptions, which we have listed here on the screen. Generally speaking, some of the most important assumptions are going to be is what medications prescribed for weight loss. Most of our modeling to date has used Wegovy. What's the medication cost? Generally speaking, our model is assuming about $13.50 per month in a GLP-1 for a gross cost. For the non-GLP-1s or the first generation of obesity treatments, that's a much lower cost per month after de-escalation. What's really important to consider when you're calculating your net liability for any pharmacy expense is you must consider member cost sharing, and you must consider rebates by the brand drug manufacturers. Throughout this work, we've assumed around 45% of the drug cost will be recouped through rebates. Through converse with entities in this space, we believe the average employer rebate on a drug like this is going to land somewhere between 30 and 50%, depending on specific PBM agreements. On top of that, we've seen a wide variety of member cost sharing, anywhere from 0 up to even as high as 125 for the drug. And that's really improves all impact the net liability for every prescription filled. Additionally, what's very important to consider is the starting obesity prevalence. In certain areas or markets or certain employers, you could expect to see a greater outcome or ROI if there's a high prevalence of maybe class 2 or class 3 obesity relative to the national average. So far for this work, we've relied on national average statistics. Generally speaking, on the defensive model, what will be very impactful is the length of time the GLP-1's been prescribed, and that's a parameter that the Weight Watchers to adjust throughout their modeling process.
Thanks, Rich. Amy, any specific comments you can make on really the de-escalation and some of the thinking behind the time on GLP-1?
Sure. So regarding de-escalation, first thing is really important to try to identify who we think would be a good candidate. And I did see a question come in, also asking about who's the best person for a GLP-1. We recommend following the FDA-approved guidelines, which would include people with a overweight classification of having a BMI of 27 or greater and having an obesity-related comorbid condition like type 2 diabetes or heart disease, or secondly, having a BMI greater than 30. One myth that I like to bust on the GLP-1s, that there's some unfortunately connotation that people are going to use these medications to get into their skinny jeans and to lose 5-10 pounds. Really, to meet that BMI criteria, you need to be about 45 to 50 pounds overweight in general, if you look at all the obesity tables. Additionally, there's been a lot of focus on, is BMI the right metric that we should be looking at? Unfortunately, it's kind of like a standardized test, like an SAT or ACT. You need some type of metric, and it's the best that we have for the time being. But we do need to take that into context and to understand when it's applicable and what the actual pitfalls might be in the BMI reduction. In terms of who would respond best to de-escalation, talked a little bit earlier about individuals that perhaps have an event that's associated with their obesity that drove their obesity. They're most likely to be the best prime candidates for de-escalation. And we are actually currently running a study, so stay tuned. We can't wait to get that out there in the marketplace, because it really hasn't been studied well or published in a peer-reviewed journal about de-escalation. But we are looking at this now with both arms looking at, one arm looking at de-escalation to behavioral therapy alone, the second looking at people that we would de-escalate to a lesser costly drug, either on-label use for the earlier generation anti-obesity medications or for using a medication off-label. The other thing that I wanted to share with this group too, I recently attended a roundtable discussion with several leaders in obesity care. And one leader brought up an interesting concept, who was a CMO for a major cosmetics manufacturer. And what she had brought up really made me think a little bit differently about obesity as a population health approach. As we know that a lot of employers and payers are faced with churn, where they may not have that 2 to 3 years that Rich had talked about of having that employee under their belt to realize some of the benefits from it. What she had mentioned is that, now that most people have some type of remote care or remote home work, that people aren't picking up their bags for jobs and moving across the country. They're really staying in their same communities, and it's the same populations. So if employers within the same industry vertical covered the medication in the same population and communities, that although there's churn, as you create a healthier person and they go to the competitor's also creating a healthier population that's coming to you. So one pearl that I've been advising my employer clients to take a look at is to make sure that they're looking at new employees joining their health plan versus retained, and seeing which population is healthier or having more obesity related claims. That's one way to track. Additionally, also we're focusing on, is it the employee themselves, or is it the other covered lives under their health plan that are driving the cost? And that can help you partner with your vendors to help come up with custom and targeted programs, making sure that you're addressing the folks that need your care the most.
Thanks, Amy. I think that's such an interesting concept of really taking a different perspective and bringing employers together, like having all boats rise and sharing the opportunity to really make an impact on this, epidemic really of people living with obesity in our country. Rich, as we move into the next piece of this, we've heard about the actual two different types of value model approaches, and we've talked about the underlying assumptions. Now, as you put all of this together, what is the impact? What is the actual output or the return that we might expect as you think about both of these different models?
Yes, thank you, Eva. From an ROI standpoint, most of the specific employer evaluations we've worked on are going to range from either a 3-to-1 or a 2-to-1 over a 2-year time frame for the defensive model. And that value driver primarily comes from savings due to de-escalation of GLP-1 medications as they get transitioned to lower cost pharmacotherapy treatments. And then there's some additional utilization management that drives value there, being the on-ramp with the behavioral program, the medication step therapy, limiting the overall time horizon the members prescribed the GLP-1, and then behavioral change to support the weight loss or the continued weight loss even after de-escalation.
Great. So that's on the defensive side, right? Like, could we also look at the offensive model and how that might work in terms of the overall ROI?
Yes. And so on the offensive perspective, now keep in mind, the cost hurdle on an ROI for the offensive is much higher because we're adding the behavioral program as well as the GLP-1s. Generally, in most situations, the ROI will be up to around 1-to-1. And that's mostly because of the cost of the GLP-1 that needs to be overcome. The time frame where we've looked at the offensive model is typically over a 3-year time period. And generally speaking, it takes a significant amount of weight loss to bend the cost curve. In addition, we've looked at reductions to absenteeism to also a value driver here.
Great. One of the questions I think I see coming in relative to the medication formulary, Amy, maybe I would love for you to answer. Where do alternative medications, anti-obesity medications, fit into the equation here?
That's a great question. I think we're focusing on the GLP-1s just because they've had such significant efficacy with weight, not just the efficacy with weight loss itself, but also in terms of impacting weight health. So long-term improvements in decreasing cardiovascular disease, long-term improvement in kidney disease, and the list goes on and on and on. But there are first-generation medicines like bupropion, naltrexone, Qsymia and Contrave are some branded names that you may have heard. They're very good medications and they work and they're very effective. We certainly, in the obesity specialty, prior to having GLPs available in our arsenal, we use them regularly and a lot of patients achieve success on them. So I think that's one of the areas that we are looking at as well, as de-escalating to that very class of medications. Additionally, some employers out there are requiring step therapy to have either plateau or another indication for GLP-1 to allow it for the treatment of obesity.
That's great. One of the other things I know we've been hearing about from all the discussions we've had, if you go to the next section here, the question has come up as to really, what is the cost of doing nothing? What if would I just hold off and just wait and see how things go? Rich, Amy, any thoughts on this in terms of how someone should think about just holding tight and not doing anything?
Yeah, and so in response to that, Eva, we've demonstrated, or we've illustrated this graph here, and the unmanaged PMPY on the left is significantly higher than the managed PMPY on the right. Operating your program in an unmanaged environment, it will likely be 2 times more costly. Generally, what we're seeing is as you transition from the left of this graph to the right, the blue section, which is the drug cost, can be reduced significantly due to de-escalation. The cost of clinical costs from the providers who treat your employees for weight management can be reduced as you go from the orange bar at the top of the left graph to the gray bar at the right on the top of the right graph. And then generally speaking, there's a very similar amount of weight loss that happens under each scenario, with slight differences being driven by on-ramp and any time delays that could be put in place via the weight management program.
Yeah, thanks, Rich. And I will say on the managed model, it's so important to tightly manage this population. You're going to get greater clinical efficiency, have that close clinical partnership to have good reporting to understand in a transparent fashion how well you're making an impact on the population. We know that the medication de-escalation therapy is really where we're seeing the cost savings in medication if we're able to get it out. Also get you off the medication. Also, it's important to say that if we have a good, strong behavioral and lifestyle component, we like to call it the bookends, that up front, perhaps we can even prevent a portion of the population from requiring medication. And on the back end, you have a good, strong, solidified foundation to come back to once we are able to de-escalate specific people off of the pharmacotherapy. Along those lines as well, some of the things that we look at are, yes, it's cost avoidance of things along the way of diabetes, hypertension, but there was a comment in the comment section about NASH, which is a condition where you have liver deposits, fatty deposits, adipose deposits within the liver that can progress to things like hepatitis, cirrhosis, and ultimately liver failure, and even some liver cancers. We're seeing a substantial improvements in treating this specific consequence of living in an unhealthy weight, and certainly will be calculated in and considered in future models, but our current model really doesn't look specifically at some of the newer indications that we're seeing, including substance use disorder, some of the behavioral health spectrum, as well as liver disease. We think it's really important on the management model too, that you need to have medication based on the appropriate indication. One example I'd love to share with you is in my home state of Pennsylvania, Medicaid does cover the GLP-1s. However, we're starting to see some fraud, waste, and abuse to where, because there is not a gating requirement of co-participating in any type of managed program or lifestyle program, that unfortunately some people are actually getting the medication, filling the script, and then selling it on the black market. So something very important for us to keep an eye on. Unfortunately, it's a reality of today, and we want to make sure that people that are engaged and are committed to their own personal weight journey and their weight health are those that are receiving the medications and it's not being used inappropriately.
Amy, that's so, it's really an important point to raise. I think what we're seeing here is that the field is evolving so substantially. And not only are new medications coming to market in the horizon with new studies and information that we're learning about utilization patterns and such, but we're also seeing how what the impact is in the real world in clinical care, and how people are responding to whether they're getting coverage or not getting coverage or the like. So I think it's really important for all of us to sort of share some of these best practices, understand what kinds of obstacles and the like, not only for members who might be appropriately getting or needing this type of care, but also what it means in real life to clinicians as they're caring for these patients. As we move into this last slide, I'll just summarize some of the cost control mechanism we've talked about here as a part of a management strategy around delaying the using step therapy approaches, de-escalation, really looking at engagement and using behavior change all the way across from before, during, and after a pharmacotherapy treatment, if it makes sense. And then on the benefit side of things, what we're really seeing is improved health, weight health, and that's resulting from clinically significant outcomes tied to the benefits of weight loss, being able to help impact the days people are more present and available at work, highly productive, and then the goodwill of employee satisfaction, engagement as a resulting factor. So why don't we go ahead and stop sharing here? I'd love to take some of the questions that are flowing in. And Rich, why don't I start with you? There's a specific question around how much of the ROI sits in reduced actual medical claims versus productivity and absenteeism. If you can shine a little bit of a light on that.
Yeah, I don't have a specific answer because it'll depend on specific assumptions related to your employer. But when you're thinking about, keep in mind the starting distribution of where the employees are on the obesity scale. So if you have a high distribution of members that are at a class 3 or higher obesity, you'll see a larger distribution of reduced claim expense. On top of that, when we've calculated the value of absenteeism, generally we've assumed that there'll be a few less days employees will miss around 1 to 2 less days of work per year, which has been supported by our research. And the value of that day of work is going to depend generally on how much those employees are paid. And we've assumed that there's a 2x value creation factor. So it's hard to give you a specific answer, but through a consultation, we could probably give you an answer that's designed specifically for your situation.
Great. There's also another question I see about rebates and how the rebates might work with GLP-1s and how they might be factored in into the conversation here, into the model.
So yes, rebates are used to offset the gross cost. When we calculate the net cost of the drugs, what we've applied is we start off with the gross retail price, and then we apply rebates as well as member cost sharing to calculate the net pharmacy liability. Generally, the rebate distribution that we've seen is going to range from 30 to 50% of ingredient costs.
Amy, there was a question earlier on about just in terms of the length of time and turnover from an employee perspective. I know you mentioned one of the use cases or one of the examples of an employee you spoke with, but I think in terms of thinking about the employee length of time somebody might be at an employer or a payer organization, would they see some sort of return in a shorter period of time?
That's a great question. Of course, actually, and I want to kind of plug into that question. I saw something else about dealing with the geriatric population that perhaps maybe at an employer and certainly may not have remote work or in rural areas. So I kind of want to pull that one in there in as well. So a couple things in terms of the ROI itself. Again, it depends on some of the things that Rich called out. Your population at baseline, where does your population sit? I think that's the first question to ask in terms of the obesity spectrum. And has the prevalence of obesity increased more than what you would expect or less in terms, or actually gotten better in terms of your population? And most employers to date have some type of solution in place already that looks at overall weight health or lifestyle management in general. So the question is, how well are those activities performing, and are your employees engaged in utilizing them? I think first step in answering that question is understanding your own population at hand, and that can help predict more quickly how you can get some type of benefit. But it is tricky these drugs are expensive if that's your exclusive lever that you're using to see an ROI in 2 years or less. Now, talking about the geriatric population, the number one risk factor for obesity is age. And so as we age, it becomes more challenging for all of us to have lean muscle mass. And we see a lot of muscle wasting as well. And that's something that I did want to mention to this group while I had the opportunity, is it's also important for those that you choose to cover GLP-1s for the treatment of obesity, that it becomes less about getting a certain caloric content or reducing your caloric content per day, but really making sure about getting the right macronutrients. Patients really, they lose that noise that drives them to eat. So I actually worry more so about people, particularly in the geriatric population, getting enough nutrients so they don't end up with hip fractures and the right types of minerals to make sure they have good bone density. So doing that, making sure the right macronutrients and making sure that people have some type of fitness regimen. It doesn't mean that you're on a journey to running a 5K or a marathon, but doing resistance training to make sure you can preserve as much lean muscle mass as possible is absolutely critical to success and as part of one of the components of a treatment program. And in terms of the Medicare population specifically, we know that the TROA, Treat Reduce Obesity Act, has been on the docket for Congress. We're not overly optimistic that it'll go through anytime soon because it does add significant expense to Medicare's already challenged budget, if you will, to cover those medications. So certainly presents some issues there. I would say one thing that's really important with the geriatric population, whether you're covering again the medication or not, is that you have a relevant program that helps engage the population to make sure they're moving appropriately, they're sleeping appropriately, and that someone's done a comprehensive end-to-end review of their current medications to make sure that they aren't on medicines that are driving obesity, where simply switching brands to a non-obesity-genic medication could really solve the problem, and perhaps they won't need to be escalated to a GLP-1 therapy.
Thanks, Amy. I see another question here, Rich, coming up, wanting to dive a little bit more on the productivity lever and the absenteeism and what we're seeing over the course of time. Are they is a productivity lever around conflict, burnout, absenteeism, employee goodwill. Can you share a little bit about your thinking in that value driver?
Yeah, so those are going to all be value levers, but really specifically in our ROI modeling, it's difficult to put a financial dollar and cents number on some of those levers, right? Burnout, for example, it's hard to apply an actuarially sound dollar amount to that, or goodwill and trust among your employees. From a financial levering modeling perspective, we've really focused on the absenteeism, and our modeling is focused on the absenteeism rate of healthy weight individuals compared to higher BMI individuals, and there is a difference there. When we've done our modeling, we've applied dampening factors to account for the fact that an employer could have many individuals on their coverage, but only one of them, because maybe you're getting family coverage, only the employee would actually benefit from the absenteeism, which we've built into our modeling through dampening factors.
Thanks. And I think we have maybe time for one more question, which there's a question around the managed versus the unmanaged population chart that we had that you talked through. And the question is, does the unmanaged group include the use of prior authorization or coverage of weight loss meds without utilization management strategy? So how does a prior authorization fit into that sort of definition of managed versus unmanaged?
Yes, and so it's considered, but that graph is downstream of the prior auth process. So that's on a per participant per year basis. So that's assuming that member would meet the prior authorizations process under each process. Does that make sense?
Yeah, thanks, Rich. So what you're saying is essentially the right now the unmanaged population is really a group of people that right now there might be some very small, low level kind of traditional prior auth processes that are at play, but are not necessarily in what we call the fully managed version because they haven't been deployed at scale in many places as well.
That's correct.
Okay, great. Well, I think there's been a lot of content covered here today. Thank you for joining us today. As we learned from Rich and Amy, that ROI is such an important consideration as you're evaluating various healthcare interventions that are expensive and also maybe burdensome to administer. And it's really helpful to make data-driven decisions along the way. We want to thank Amy, you and Rich for joining us today, also the audience today for being here. We hope you gained valuable insights as we explored the ROI and also the clinical importance of GLP-1s. At Weight Watchers, we recognize that weight health is a journey. Our full spectrum weight health platform brings together our evidence-based program, the gold standard for behavioral weight loss, combined with individualized pathways and interventions based on true clinical need. It's important that we find partners to serve our entire population across different acuity levels and provide these individualized experiences with behavior change alone and then with clinical intervention that have a return on investment across the weight health spectrum. We're guiding members through their journey to long-term weight loss with behavioral, social, clinical, and functional support. For more information on our full spectrum weight health platform and how our pathways can enable access to effective treatments while still managing costs, please visit us online at www.com/for business. We'll also be sure to share some of these additional education pieces for download following the presentation. Thank you again to Santa Barbara Actuaries, Dr. Amy, and to all of you on the line for joining us today, and I hope you have a great rest of the day.
Thank you to our speakers and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Los Angeles, February 25th through 28th for VIVE 2024.